We're going to go ahead and get started. Sorry for the delay. For those of you that I haven't met or don't know very well, I'm Emily Burns. I'm one of the PGY1s here, and we'll be staying on next year for cardiology. So my presentation is called VADs Gone Bad, Pump Thrombosis and Gastrointestinal Bleeding in Patients with Left Ventricular Assist Devices. By the end of this presentation, I hope that you'll be able to outline the indications for left ventricular assist devices and the devices commonly used, explain anticoagulation and antiplatelet strategies for LVAD patients, and to discuss the causes and management of pump thrombosis, along with evaluating emergent and long-term management of gastrointestinal bleeds. So the first thing some of you are probably wondering is, what is a left ventricular assist device and what does it do? This is the #1 form of mechanical circulatory support worldwide, and it's used for patients with advanced heart failure. You can see in the image on the left that it generates additional blood flow in parallel with what the left ventricle is doing. So there's an inflow cannula that takes blood out from the left ventricle, puts it through a pump, and puts it back out through the outflow cannula in the ascending aorta. The purpose is to unload the left ventricle and to reestablish normal cardiac output. Modern devices are capable of generating about 10 liters per minute of flow, and so normal cardiac output we consider is in a range of 4 to 8 liters per minute. So next question is, do we really need LVADs? We have heart transplants, right? So while heart transplant is the definitive therapy for patients with advanced heart failure, the U.S. population is growing, and there's expected to be more than 8 million adults in the U.S. with heart failure by 2030. So if you consider that we do about 2,400 heart transplants per year, plus there are about 3,600 actively listed adults for transplant, that comes out to over 1,200 patients that are not getting transplanted. So transplant growth has really only been limited by the amount of donors that we have. So this leaves some patients left over that aren't able to get transplants. So this is a patient population that has refractory heart failure despite optimal medical management, and they're most likely on some sort of inotrope support to bridge them to transplant, but we know that is, from a mortality side, suboptimal bridge to transplant. Which brings us to how we got to mechanical circulatory support. So a little bit of background: in the 1950s, the Gibbon heart-lung machine was used to do the first complex open heart surgery. This was followed a few years later by the first LVAD that was implanted. It was a very short-lived success. And then a few years later, the first heart transplant in Cape Town, South Africa. However, the patient only survived 18 days. And they were really focusing on heart transplant at this time, but after several early failures of transplants, they realized that there were some immune issues that they hadn't quite worked out. So the focus shifted back to artificial support. You can see in '69, the first artificial heart as a bridge to transplant was completed. And then finally in '84, the first successful LVAD to transplant was completed. In the United States, in 1994, the FDA approved the first LVAD as a bridge to transplant. And then finally, in 2001, the REMATCH results were published, which opened the use of LVADs to a different patient population. The REMATCH trial was published in the New England Journal of Medicine in 2001, and they set out to compare the use of these LVADs long-terms in patients with class 4 heart failure that were not eligible to transplant, and compared them to patients receiving optimal medical management. You can see in this graph with percent survival on the y-axis and months on the x-axis that at 12 months in the pulsatile LVAD group, these are the earlier generation LVADs, 52% of patients were surviving to 12 months compared to only 25% in optimal medical management. In terms of duration of survival, the median survival in the LVAD group is about 400 and some days, and in the optimal medical management was about 150 days. And this all came out to a 48% decrease in all-cause mortality. In 2005, in North America, the INTERMACS registry was established by the FDA, the National Heart, Lung, and Blood Institute, and CMS, called INTERMACS. It's a database of all mechanical circulatory support in North America, and it publishes trends and analyzes databases to see what adverse effects are upcoming and how LVADs are being used. This is one such of those graphs. You can see of implants per year by device type. The y-axis is the number of implants per year, and the x-axis shows the years since INTERMACS has started collecting data. LVADs specifically are in the bluish purple color. You can see they also included RVADs, or right ventricular assist devices, and BiVADs for both ventricle along with total artificial hearts. So you can see that from 2009 till current, the amount of patients receiving LVADs has just continued to grow. This also excludes any patients that are receiving LVADs as part of any investigational study. So you can see more and more patients are getting LVADs. However, it looks like this has surpassed our donor supply for transplants available. This is another Intermax graph with the number of patients implanted on the y-axis in year, separated by device strategy. So at the time that they received their LVAD, what was their intention of treatment? The green color is the patients or destination therapy. These are patients that are ineligible to transplant. So you can see this also has grown exponentially and has surpassed the amount of patients that are receiving listed as a bridge to transplant. So we already talked about destination therapy and bridge to transplant as indications for LVAD, but there also is this gray area in between of patients that it's still not decided at time of implant what's going to happen. There are patients that need a little bit more time and support because they aren't going to make it to transplant to decide if they are candidates. Some patients need to lose weight before they are candidates, or they may have some organ dysfunction that's going to preclude them from a transplant, and so they need time to recover. Other patients have some sort of acute onset injury, such as myocarditis, and may only need temporary LVAD support and can eventually have their device explanted. So indications for bridge to transplant patients, they're basically failing optimal therapies and they are at high risk of dying before they receive their transplant. Destination therapy patients are ineligible for transplant and have a high 1-year mortality risk. Exclusions for bridge to transplant, it's generally what you would think of for patients that would be eligible for a transplant itself. And along with destination therapy, there is really no established hard age limit for that. And some centers are implanting patients older and older. In both groups, you need to have adequate psychosocial support. It is a huge lifestyle change. And you also can't have any recent or evolving stroke history, as these patients will need to be anticoagulated. And so you can see that 45% of patients are now listed as destination therapy when they are implanted, and this number is expected to continue to grow. The main reason for this destination therapy growth has been the FDA approval of a newer device called the HeartMate 2 that was approved for destination therapy in 2010. So this brings me to an important point about LVADs. They're not all the same and they're not all equal. The older generation LVADs were called pulsatile flow devices because they generated blood flow in a pulse like normal blood flow. These were volume displacement, so they were large and sometimes impeded with patients eating. Their stomachs would feel full and they couldn't eat a lot. The devices are loud. They had a lot of interacting parts, so they didn't last as long and they were very noisy. Current devices commonly used are continuous flow or non-pulsatile devices, so they just have continuous blood flow and may not have a palpable pulse. These devices are about 1/7 of the size of the pulsatile flow devices, and due to decreased interacting parts have improved reliability. They also have improved survival and quality of life and reduced event rates. So obviously now that we had these new continuous flow devices, we had to compare the two designs. This study looked at destination therapy patients comparing the pulsatile device, the HeartMate XVE, to the continuous flow device, the HeartMate 2, in 200 transplant ineligible patients. This graph shows a patient's probability of survival on the y-axis and their months since randomization on the x-axis. So you can see at 24 months, 58% of the continuous flow LVAD or HeartMate 2 patients had survived compared to just 24 in the pulsatile flow devices. And this is what led to the approval of the HeartMate 2 as a destination therapy. And then finally, a few weeks ago, the Momentum trial comparing the newest LVAD was released. It's called the HeartMate 3. This is new in that it's able to generate a pulse by changing rotor speed at set frequencies and may decrease some of the complications that I'm going to talk about. So just to review the current devices that are most commonly used, the HeartMate 2 has a larger inflow cannula, so it actually has to be inserted into the intraperitoneal space as well, and it's approved for destination therapy and as a bridge to transplant. The HVAD has a smaller inflow cannula, so it can be implanted only in the pericardial space, and it is destination therapy and bridge to transplant as well. And then the HeartMate 3 is the newest one that I was just talking about. It's fully magnetic, and it's capable of generating a pulse, like I mentioned earlier. And I included it on here because it is still investigational, but you will see patients at UVA that receive the HeartMate 3. So this brings me to my first question. Which of the following regarding mechanical circulatory support is true? A, the surplus of donor hearts mean many patients do not need LVADs. B, more patients are receiving LVADs as destination therapy than as a bridge to transplant. C, more patients receive total artificial hearts than LVADs due to the need for right and left ventricular support. And D, pulsatile flow LVADs have a higher 2-year survival because they create a pulse that mimics normal blood flow. Correct, B. More patients are receiving LVADs as destination therapy than as a bridge to transplant, and that gap is expected to increase. So I want to introduce you to our patient case. AK is a 63-year-old female that is being worked up for an LVAD. Her past medical history includes non-ischemic cardiomyopathy with an ejection fraction of less than 15%, along with rheumatic disease with a mitral valve replacement in 2009. She also has pulmonary hypertension and atrial flutter that was converted but complicated by a CVA that has some residual effects. She also has hypertension and CKD. The heart failure team decides she is a transplant candidate and requires mechanical support to bridge her to a transplant. However, first the patient wants to know a little bit more about complications of LVADs. So there are many potential complications from having an LVAD that range from infectious complications. You can get an infection of the driveline as it inserts your body, all the way to a pump pocket infection. And these can all be very difficult to eradicate without proper source control, which is difficult without a device exchange or a transplant. The cannula, inflow cannula, can also get obstructed. These are called suction events. The inflow is pulling blood from the left ventricle, and it gets obstructed by the left ventricle myocardium itself, and it sort of gets sucked in. And this can happen if patients are hypovolemic or if the inflow cannula is malpositioned. Patients can also experience right ventricular failure. They are heavily worked up for this pre-implant, but it can happen afterwards as well. Patients also may develop arrhythmias along with aortic valve disease. And then finally, bleeding and thrombosis, which is what I'm going to focus on today. These can range from nosebleeds to strokes and can be caused or in response to the maintenance antithrombotics that these patients have to be on. So due to the implantation of foreign material plus the risks if the pump stops working, these patients are on chronic anticoagulation and antiplatelets. The standard regimen for anticoagulation is warfarin. They're bridged after implant using mainly heparin. Some centers may use an IV direct thrombin inhibitor or low molecular weight heparin. And then aspirin is the standard antiplatelet agent, and you can also include potentially clopidogrel or dipyridamole, depending on the indication and the other comorbid factors. Looking at anticoagulation specifically, I've included the recommendations from the device manufacturer and then the International Society for Heart and Lung Transplant specifically for each device. So you can see for the HeartMate 2, they both recommend starting heparin post-op. It's a little bit later in the guideline recommendations, and then titrating up to a higher APTT goal as long as there is no obvious bleeding. And then starting warfarin by post-op day 3 to 5 with an INR goal of 2 to 3. For the HVAD, again, heparin is recommended to bridge patients to warfarin, and warfarin goal again here is an INR of 2 to 3. For antiplatelets, aspirin is recommended for both devices. In the HeartMate 2, low-dose aspirin plus dipyridamole is recommended, whereas the guidelines recommend a range of aspirin doses but do defer to the manufacturer. For the HVAD, the manufacturer recommends high-dose aspirin specifically unless there is evidence of aspirin resistance. And the guidelines here, again, recommend a range. At UVA, we do 325 milligrams of aspirin with an INR goal of 2 to 3 with warfarin for both devices. So you're probably wondering about direct oral anticoagulants and whether or not they could be used in this patient populations. There are a few case reports available. The first one is on dabigatran used in Greece, and then apixaban used at a center in Germany. However, the guidelines currently say, although these alternatives have been approved by the FDA, they have not been adequately studied in the mechanical circulatory support device population, and thus are not recommended. And I would say that those guidelines echo current practice. So our patient went ahead and decided to get her LVAD. She's now post-op day 3 from her HVAD implant. And the team wants to know which of the following is the most appropriate combination to start. I heard C. C's correct. B and D are obviously incorrect, and then the standard here would be to do C. So moving on to our first major complication, pump thrombosis is one of the thrombotic complications that can occur after device implant and is a devastating complication of LVADs. So to define pump thrombosis, it's a thrombus in the device or the conduits with symptoms of impaired pump function or the need for thrombolytic or surgical intervention. You can see in the image on the right, there's generally 3 different areas you can consider a thrombus having formed, pre-pump, intra-pump, or post-pump. Pump thrombosis is again separated into confirmed or suspected pump thrombosis. Confirmed requires direct observation of the thrombus. And this is usually only seen upon device explantation, taking a look at it, and you can find the thrombus. Most patients have a suspected pump thrombosis, and this is based on 2 or more of 3 clinical findings: the presence of hemolysis, which I'm going to explain in a minute, the presence of heart failure that's not explained by structural heart disease, and abnormal pump parameters, as the device will try to compensate to maintain the same support. The pathophysiology of this is very complex, and the exact mechanism is unclear, but it is likely due to a multitude of factors. As I said earlier, these newer continuous flow devices are smaller, and this puts more shear stress on blood as it goes through the rotor. This increases the amount of hemolysis, or red blood cells, that open, and so you get an increase in products from that of hemoglobin and lactate dehydrogenase, or LDH, as you see on here. And some of these byproducts will lead to a reduction in nitric oxide, which is needed to help mediate platelet activation. And the platelets can also be activated themselves just by the turbulence going through the device, and then there's also heat generated by the device itself going through the rotor. So all of this culminates in a prothrombotic state and increases the risk of forming a clot. So in the past few years, there's been an increasing concern about pump thrombosis. The first was a report by Starling and colleagues on the HeartMate 2. They looked at 3 centers specifically: Cleveland Clinic, Duke, and Barnes Jewish Hospital. They're all reporting an increased incidence in pump thrombosis. You can see in this graph the percent of patients with confirmed pump thrombosis on the y-axis, along with the implantation year on the x-axis, that it increased from 2.2% overall in 2011 to 8.4% in 2013. And they also noticed that mortality with medical management, so without any surgical intervention, was approaching 50%. So there was also an analysis of the Intermax database for the HeartMate 2, and they found a 6-fold increase in the rates of pump thrombosis in 2011 and 2012. And you can see in this graph, it's on the y-axis, the percent of patients that are free from device exchange due to thrombus, along with the months post-implant, and it's all stratified by the year that they were implanted. So there's been an increasing amount of events as patients have been implanted in later years. And then in terms of the HVAD itself, they also noticed an increase in events from 0.03 to 0.07 events per patient year. They found some independent risk factors for this were an INR of less than 2, or anybody that was on 81 milligrams of aspirin or less per day. So this led to more strict recommendations about INR goals, along with recommending that everyone be on 325 milligrams of aspirin. And after they did that, the incidence of device exchange for thrombus decreased over 50%. Unfortunately, there's not a single test that can tell you that the patient has a pump thrombosis. Common things you may see are signs of decompensated heart failure, as you would expect if their LVAD isn't able to adequately support them. They can also have increased power requirements on their LVAD. So the devices are set at a certain speed, and they may need to increase the power to maintain at that same speed. You can also use echo and see if the heart is functioning as it should, if the LVAD was functioning normally. And then finally, evidence of hemolysis. So you'll get an increase in LDH and plasma-free hemoglobin. LDH has been found to be a more specific marker for pump thrombosis and is regularly trended after implant and to establish a baseline for patients so that they can tell if a patient is going to develop a pump thrombosis. Along with T-colored urine, so this may be the only sign a patient has of an early pump thrombosis. They'll come in to clinic and say that their urine looks T-colored. So you can see at the bottom that pump thrombosis is really a continuum. It starts with the thrombus initiating, so this is where you'll see signs of hemolysis, but there's no hemodynamic changes at that point. And then the thrombus will be incomplete, but you'll start to see some changes in the pump function. You may see some power spikes. And then finally, a complete thrombus would result in pump stoppage, and the patient would go into cardiogenic shock. There's 3 different groups of risk factors that we typically think about that put patients at risk for pump thrombosis, divided into patient, device, and management related. Patient-related factors are things like a hypercoagulable state, AFib, a left-sided mechanical prosthesis. And then device-related could be surgical things or the heat generated by the rotor itself, along with platelet activation from the shear stress. And then where we really can have an impact in the management, trying to make sure that patients are therapeutic on their INR, or if they should be on an antiplatelet agent, that they're at an appropriate dose or potentially adding more. In terms of managing pump thrombosis, there are several treatment options. The first one would be intensifying their anticoagulation. So if they are not therapeutic on warfarin, you can get them therapeutic. You can also consider increasing your INR goal range. You can also use IV heparin or IV direct thrombin inhibitors, either as a bridge to get their INR in a therapeutic range or to anticoagulate them. You can add additional antiplatelets, either parenterally or enterally, with the GP2B3A inhibitors or clopidogrel or dipyridamole if they're not already on them. And then you can also potentially use fibrinolytics with TPA either intravenously or in the cath lab injected directly into the left ventricle. And then finally, surgical management. Patients can have their device exchanged or receive an emergent transplant if they are candidates. So there are many proposed algorithms out there available on how to manage pump thrombosis. Unfortunately, there isn't a set one per guidelines. I chose this one because it was published by 2 UVA surgeons, Drs. Alawadi and Kern, along with one of their colleagues at UPMC. So you can see, I know it's busy, but patients with evidence of hemolysis are admitted to the hospital. They're started on a parenteral anticoagulant, usually heparin first, but this is also center-specific. And then you can escalate as needed to potentially a GP2B3A inhibitor or an IV direct thrombin inhibitor if their symptoms are unresolved. And then potentially you could add a thrombolytic, either intraventricularly or intravenously. If their symptoms are resolved, we usually consider a returning of their LDH to baseline, urine color returning to normal, and no power spikes on their device. You can consider increasing their INR range, putting them on high-dose aspirin if they were on low-dose aspirin before, or adding a second antiplatelet agent. If their symptoms continue to be unresolved despite these agents, or if they have severe hemodynamic compromised state, you may want to consider an LVAD exchange or an urgent transplant, again, if they are candidates and their prognosis from surgery would be good. So the first agent I'm going to talk about is IV unfractionated heparin. Najjar and colleagues took the data from the HVAD bridge to transplant and continued access protocol and tried to analyze it for characteristics that may put patients at risk for pump thrombosis and to really get an idea of the incidence and treatment outcomes to compare different treatment strategies. So of the 382 patients in that trial, there were 34 pump thrombosis events. 30 of those were managed medically initially, and of those, only 5 were initially managed with heparin monotherapy. 25 other patients received heparin in combination with some other treatment. Overall, medical management was 50% successful. However, heparin monotherapy was not successful in any of the 5 events that were treated. 4 of those patients required a device exchange, and then there was 1 emergent transplant. So the authors concluded that heparin may have a role as an early treatment strategy in patients that have not developed significant hemodynamic compromised states. And it's also unknown who is going to benefit best from medical therapy or device exchange. Moving on to the IV direct thrombin inhibitors. These are thought to use because they can bind fibrin-bound and unbound thrombin, and they're also less immunogenic than heparin, and this is a patient population that is at higher risk for developing HIT. Bivalirudin can be used. It is primarily enzymatically cleared, but it does have renal dose adjustments, and argatroban is going to depend on liver function. Potential issues with these drugs is it is hard to get patients in a good therapeutic range and transition them successfully when you're bridging to warfarin. And also the doses in this indication are not standardized. So I looked at 3 different case series of patients that received IV direct thrombin inhibitors. The first case is one patient by Remsons and colleagues that was on warfarin and aspirin high dose. He had a history of pump thrombosis and device exchange previously, and he was managed by a pharmacist-run anticoag clinic, so they knew that his INR had been therapeutic for the previous 96% of 90 days, and his INR goal was 2.5 to 3.5, so he was already on the higher range. So he's admitted and started on bivalirudin with a higher APTT goal of 80 to 100 seconds, and also added dipyridamole. He did have a clinical response. His LDH peaked about 3 days after admission, and he received a total of 16 days of bivalirudin, and there were no reports of bleeding or other adverse events in this case. The next case is Sylvia and colleagues. This was 10 events in 6 different patients. They were all on warfarin and aspirin, and then some were on different antiplatelet agents. And here bivalirudin was started. They included the dose in this case report of 0.03 to 0.15 milligrams per kilogram per hour with a PTT goal of 60 to 75. Of these, they said 9 patients clinically responded. However, 3 later required a device exchange, but this was all greater than 100 days after completing bivalirudin. You can see the duration of intervention is a huge range from 11 to 237 days. Some patients were maintained on it until they had their device exchange or received their transplant. Of these patients, only 1 reported a minor bleed. And then the final case series is Badier and colleagues. This was 4 patients with 4 events in HeartMate 2. They were all on warfarin, and these patients were treated with argatroban, and 1 also received dipyridamole. Of these, they say that 3 probably responded, but there were also 2 major bleeding events. 1 patient, while she was receiving argatroban, fell and hit her head and developed a subdural hematoma that had to be evacuated, and the other patient developed a hemopericardium. However, both of these patients were able to later resume anticoagulation and be bridged to warfarin for discharge. And these 2 patients were also the only ones that had not left the hospital since receiving their LVAD, so they were more immediately peri-op, and they may have been at a higher bleeding risk already at baseline. So overall, direct thrombin inhibitors are potential anticoagulation option in these patients. The optimal dose is unknown, and these may be more beneficial in patients that are earlier on in their thrombus course as part of an early treatment strategy. Moving to antiplatelet agents, glycoprotein 2B3A inhibitors can be used. The rationale for this is it's really blocking the final step of platelet aggregation, so these are very potent antiplatelet agents. I included the 2 that we have on formulary here, Octreotide, which is enzymatically cleared but does have renal dose adjustments, and abciximab, which has a longer half-life. It can take up to 48 hours to see platelet recovery, but it does have non-renal excretion, which may be why it would need to be used in these patients. Potential issues with these drugs, they're very high bleeding risk. They can cause profound thrombocytopenia, and it's also unknown which doses should be used. Typically, these are used in the cath lab for PCI, and patients receive a bolus and then an infusion. So it's unknown if that would be the best way to manage patients in this case that received it, because they also do have a bleeding risk. The largest case report to date on using these agents is Teller and Cogley's. This was a single center of 17 patients with 22 episodes of suspected pump thrombosis. At admission, 41% already had evidence of LVAD dysfunction. They either saw something on the echo or there was some alarm going off on their LVAD that made them think that they had a clear thrombus. These patients received eptifibatide without a bolus. They were started an infusion of doses ranging from 0.1 to 2 micrograms per kilogram per minute, and over half of those were also receiving heparin at the same time. So of these 22 attempts, only 3 had a resolution of their pump thrombosis, and there was bleeding in 65% of the patients during the infusion, 5 gastrointestinal bleeds, and 4 hemorrhagic strokes. And overall, almost 50% of the patients passed away. So these authors concluded that the risks of this agent outweighed the benefits in terms of salvaging the device to avoid surgery, and this is putting patients at a high bleeding risk. These patients also might have had such a well-formed clot that these agents weren't going to work anyway, since they already had evidence of LVAD dysfunction at admission. The next case is Bellam-Konda and colleagues at Yale. This was another case report of 4 patients with HeartMate 2 LVADs that developed pump thrombosis. These patients were all on aspirin along with warfarin. All patients were in the 2 to 3 INR range, except for one that had an INR of 1.8. These patients were initially trialed with heparin and high-dose aspirin at the PDT goal of 60 to 80, and then after that failed, they switched to eptifibatide. These patients did receive a bolus and then were started on the infusion. Of these, only 1 of the 4 probably responded, and this is the only patient that didn't have power elevation at presentation. This patient then later had a device exchange, and upon that time, they did not find a thrombus present. The other patients, when they had their devices eventually exchanged, there were well-formed thrombi present. The authors here again concluded that there is a limited role for eptifibatide, and it may again be useful early in clot formation before these patients are developing some sort of hemodynamic compromise. And then finally, for pharmacologic management of pump thrombosis, fibrinolytics can be used, IV or intraventricularly into the left ventricle in the cath lab, although this is known to have a very high bleeding risk, as we all know. This is a case series from Duke of patients with recurrent or refractory hemolysis. These patients were initially managed with heparin, high-dose aspirin, and a few received GP2B3A inhibitors. They were all given alteplase in the cath lab injected into the left ventricle. Of these, 3 of 8 were successfully treated. 2 of those did have a successful resolution of their thrombus, but later developed neurologic complications. One had developed an intracranial hemorrhage 5 days after receiving TPA, and one also developed an embolic stroke. So this was a potentially very risky intervention. The authors concluded that it is a good minimally invasive alternative to surgery, but the morbidity and mortality may outweigh any potential outcomes from receiving surgery itself. So now that I've gone through all of that, you're probably wondering, does any of this work? Medication management is associated with high bleeding risks, especially with the GP2B3A inhibitors and fibrinolytics. The trial I talked about earlier, the HVAD Bridge to Transplant trial, did mention a 50% failure rate of medications, and the HeartMate 2 trial showed that there was a 48% mortality in patients that were medically managed alone. However, medications may provide a good early treatment strategy if you can catch patients early on enough, and it may avoid surgery. It does not require patients to be downgraded on their UNOS listing if they are a transplant candidate. And patients that receive a device exchange, they have to be temporarily downgraded until they have recovered, and then they can be listed again. It may be a less costly alternative to surgery. 10 weeks of bival is about the same as 1 device exchange. And it is a less invasive alternative to surgery. However, we know that after each subsequent device exchange, the 12-year mortality decreases. So it's not the same after your first device as after your third device, and you have a much higher risk of mortality with each subsequent device. So going back to AK, she's now 6 months after receiving her LVAD, and she's presenting to clinic reporting some red-colored urine. Her HVAD is showing no recent power spikes, but you get some labs and you get an LDH of 1500 with a baseline of 400 to 500 and an INR of 1.8. She was currently on warfarin 2 milligrams a day and high-dose aspirin. The team decides to admit her, and they would like a recommendation to manage her possible early pump thrombosis. What do you all recommend? B. B is correct, especially because she was subtherapeutic on her INR. You could continue the warfarin and add on heparin. So to summarize management of pump thrombosis, frequent monitoring may minimize the risk. These patients get frequent LDH levels to sort of try to catch anybody before it goes too far. And it also depends on if patients are presenting early versus late, and also whether or not they're a surgical candidate if you have that as an option in case medical management fails. The other issue with this data is it's all from case reports. To evaluate your options, there is a publication bias here. It's probably unlikely that heparin would get published if it was successful. The algorithms that I showed and the other ones available are all based on expert opinion, along with the guidelines is all based on expert opinion. And most hemodynamically unstable patients are going to receive surgical treatment. And we also know that the thrombus pathophysiology may differ in these two devices, so it's unknown if you can extrapolate the data from one device to another device. So that brings us to the other end of the spectrum. Gastrointestinal bleeds is another big complication of patients with LVADs. It's known to occur in 20 to 40% of anticoagulated patients with continuous flow LVADs. 34% of patients have more than one event, so these are patients that are frequently readmitted for GI bleeds. It's also known that the incidence is increased compared to patients with pulsatile LVADs and cardiac surgery peers that may be on anticoagulant and antiplatelet regimens as well. This is the most common cause of readmission in this patient population and the most common adverse event, and it's associated with high morbidity and high cost as well. The pathophysiology here, again, is not fully understood. It's thought to be due to two different mechanisms. The first is acquired von Willebrand syndrome. This is similar to Hyde syndrome and critical aortic stenosis, where the patient's von Willebrand factors uncoil and are exposed to proteolysis by certain enzymes, so you lose your high molecular weight von Willebrand's factors, and this leads to impaired platelet-mediated hemostasis. It's also thought that due to the lack of pulse pressure in these patients, that you have a lack of perfusion to your gut, and this may lead to development of AVMs as well, which will all lead to potential bleeding through the GI tract. Bleeding can occur all throughout the GI tract, and it's often not found on endoscopy. Melena is the most frequent symptom patients will present with, and the most common found one is AVMs in the small intestine. These patients are known to be at high risk already because they take chronic antithrombotics. Patients with higher, older age are known to be at higher risk, along with duration of support. For treatment options for GI bleeds, these are stratified into acute treatment and long-term treatment. For acute treatment, these patients have lost blood, so many patients will receive blood. The average is 3 to 4 units of packed red blood cells transfused per each GI bleed event. However, there are risks specific to this patient population with giving them blood. This will increase their sensitization and may decrease their probability of finding a heart donor match and may increase their wait time. It's also known that this can increase their risk of antibody-mediated rejection and overall graft survival. You also have the option of holding antithrombotics if patients present with a GI bleed, reversing anticoagulation, and then, like other GI bleeds, acid suppression. Long term, you can make changes to their antithrombotic regimen. You can lower their INR goal or remove some antiplatelets, or potentially remove warfarin altogether. Octreotide is another drug that is commonly used for GI bleeds. And then the last four are more investigational, infrequently used: thalidomide, danazol, and von Willebrand factor, along with proposed doxycycline. So here again, the best management of their current anticoagulants and antiplatelets is unknown during a GI bleed. The guideline recommendations are to hold for a clinically significant bleed and to continue to hold until the bleeding is resolved unless there is evidence of pump dysfunction. And this again is expert opinion. So first I'm going to talk about anticoagulation reversal. This was a study of 25 patients with 38 reversal events, and these were for all different bleeding events. You can see that for all bleeding indications, 100% of patients were given vitamin K, either IV or PO. PCC and activated factor 7 were infrequently used, and they were only used for patients that presented with intracranial hemorrhages. Of all these patients, there is only one thrombotic event within 30 days from receiving these drugs, and it was an intracranial bleed that developed into an ischemic stroke. In the same study looking at GI bleeds specifically, there were 8 events. Half of these received FFP, and all of them received packed red blood cells. You can see for the outcomes of the 8 attempts, they all received vitamin K. The majority received IV vitamin K, and there were no 30-day thrombotic or mortality events. So the conclusion from this is that the degree of bleeding should really guide your potential reversal strategy. PCC and activated factor 7 should be reserved for life-threatening situations, intracranial hemorrhages, or massive GI bleeds. And low-dose oral vitamin K or holding warfarin may be appropriate for semi-urgent procedures or asymptomatic INR elevations. When you're thinking about restarting antithrombotics after the acute bleed is over, the guideline recommends for the first bleed waiting until the bleeding is resolved and the hemoglobin is stable, and then you can reintroduce the anticoagulant and antiplatelet. If it is a recurrent bleed or they can't find a source or it's difficult to treat, you should reevaluate your type, intensity, and use of antiplatelets, and then reevaluate your INR goal or even the continued use of warfarin. And these here again are also consensus and expert opinion. For long-term management, Octreotide has the most published cases available. It's due to the rationale that it's used frequently in non-LVAD patients with GI bleeds from AVMs, so it's thought that it could also work in this. There's also data that it works in GI bleeds in patients with congenital von Willebrand's disease. So this was a case series of 7 patients that all had a history of refractory GI bleeds. They'd all received a median of 14 units of packed red blood cells. So 2 of them received sub-Q Octreotide every month, and 5 received BID sub-Q Octreotide, and this was continued for 3 months. The decision between the 2 here was purely based on insurance coverage. And while they didn't find statistical significance with their outcome, you can see a trend towards less hospitalizations, less units transfused, and less endoscopies needed. So the conclusion from this is that there's a trend towards a favorable response, but we really need a larger case series of patients to evaluate if this is potential benefit. And then Malhotra and colleagues is the only prospective study I'm going to talk about today. This is a phase 1 study that was just completed of 10 patients over 28 weeks. And these patients were all started on Octreotide within 1 month of their implant, so some of them may have not even had a GI bleed at that point. They all received the long-acting IM Octreotide for 16 weeks. There was only 8 patients that completed the trial, 2 dropped out after the initial injection. There were no side effects or complications. They didn't even report any injection site reactions, and there were no GI bleeds in this group. So they concluded that while they had no comparator, it does appear safe to use Octreotide in this population, but similarly also need a larger study group. And this is a table of proposed alternatives, agents for long-term management. Starting with thalidomide, it's proposed to be used because it's anti-angiogenic, and there's reports of its use in refractory GI bleeds due to AVMs. There are several case studies, most notably at Stanford, where they've actually developed a protocol for dosing and monitoring of thalidomide in this patient population. They start at 50 milligrams twice a day and increase depending on bleeding, and then decrease once their hemoglobin is stable and there has been no subsequent bleeding. It does require a REMS program from the patient, provider, and pharmacy to be used, and it does have a known thrombotic risk. Danazol has been used to treat AVMs and von Willebrand's disease, so there is a case report of using it in this patient population, but it is also known to have a thrombotic risk and does have androgenic side effects. Von Willebrand's factor has also been proposed to use. There's a case report of its use in Europe. They have pure von Willebrand factor available without any factor VIII in it. So there's one case report of a patient receiving this for several days. It looked like his bleeding had resolved and then it started again, so he received a combination of von Willebrand factor and Octreotide, but then had no subsequent bleeding or admissions. The issue here is mainly cost and access and potentially an increased thrombotic risk. And then finally, doxycycline is the newest drug to be proposed to work for these patients. It inhibits the enzyme that degrades the von Willebrand's factor after it's been exposed to the shear stress. So this was investigated in a lab, and they exposed blood to the same amount of stress that you would see in a patient with an LVAD, and they saw decreased bleeding and then also decreased an increase in high molecular weight von Willebrand's factors. So it is proposed to possibly work. It has not yet been studied in patients, but they did not see an increase in platelet activity as well, so this potentially has no thrombotic risk. So coming back to AK, it's now 1 year later, and she's been admitted for her third GI bleed. During her last admission, we reduced her aspirin dose to 81 milligrams daily. Which of the following might be the best option for long-term management and would cause the lowest thrombotic risk in this patient? A, discontinue warfarin, B, danazol, C, octreotide, or D, thalidomide? Here's some C's. C is correct. So to summarize management of GI bleeds, early management may be to decrease or hold their anticoagulants and antiplatelets depending on the severity of the bleed, and then reintroducing after the bleeding is resolved and the hemoglobin is stable. For late management, octreotide is most frequently used, but we don't really know for any of these what is the proper duration to evaluate a clinical response and whether or not they should be used preventatively or after the patient has experienced a bleed. And then finally, decreasing antithrombotics, you need to weigh this against the risk of having a thrombotic event, such as pump thrombosis. And it has been studied that after a GI bleed, patients are 7 times as likely to have a subsequent thrombotic event. Which brings me to my conclusion. In conclusion, it's really just balancing all these factors and walking the fine line of bleeding versus clotting in patients with left ventricular assist device, and also weighing the risks potentially of surgery in patients that do develop a significant pump thrombosis. So with that, I will take any questions that any of you all have.